Neurologic surgery provides the operative and non-operative management of disorders of the central peripheral. One include those of the brain, meninges, skull and skull base, and their blood supply, including surgical and endovascular treatment of disorders of the intracranial and extracranial vasculature supplying the brain and spinal cord, disorders of the pituitary gland, disorders of the spinal cord, meninges, and vertebral column, including those that may require treatment by fusion, instrumentation, or endovascular techniques, and disorders of the cranial and spinal nerves throughout their distribution. An accurate history is the first step toward neurologic diagnosis. A history of trauma or of neurologic symptoms is of obvious interest, but general constitutional symptoms are also important. Neurologic disease may have systemic effects, while diseases of other systems may affect neurologic function. The patient's general medical ability and understanding of neuroanatomy is the foundation of comprehensive neurologic examination and diagnosis. Salient features will be considered from cephalad to caudad. The cerebral hemispheres consist of the cerebral cortex, underlying white matter, the basal ganglia, hippocampus, and amygdala. The cerebral cortex is the most recently evolved part of the nervous system. Its functions are mapped to discrete anatomic areas. The frontal areas are involved in executive function, decision-making, and restraint of emotions. The motor strip, or precentral gyrus, is the most posterior component of the frontal lobes and is arranged along a homunculus with the head inferior and lateral to the lower extremities superiorly and medially. The motor speech area lies in the left posterior inferior frontal lobe in almost all right-handed people and in up to 90% of left-handed people. The parietal lobe lies between the central sulcus anteriorly and the occipital lobe posteriorly. The postcentral gyrus is the sensory strip, also arranged along a homunculus. The rest of the parietal lobe is involved with awareness of one's body in space and relative to the immediate environment, body orientation, and spatial relationships. The occipital lobes are most posterior. The visual cortex is arrayed along the opposing key points. One neurologic surgery specializes in primarily surgical management of central, peripheral, and autonomic nervous system disorders. Although clinical examination is paramount, neurosurgical diagnosis and treatment are aided largely by a variety of modalities, such as magnetic resonance imaging and intracranial pressure monitoring. The common treatment goals for traumatic brain and spinal injury are aimed at preventing secondary insults of hypoxia and hypotension. Aneurysmal subarachnoid hemorrhage remains one of the most morbid and intensive neurosurgical diseases. Endovascular therapy is a growing technology that allows for safer securing of ruptured aneurysms. 5 brain tumors can arise from primary or metastatic tissues. Treatment typically involves resection, followed by radiation and/or chemotherapy, depending on the type. 6, spinal instrumentation is used for surgical stabilization of many types of spinal instability, including traumatic, infectious, oncologic, and degenerative. 7, infection of the nervous system is a serious and prevalent medical problem. Operative management is indicated for most conditions in which there is symptomatic compression of neural structures. 8, functional neurosurgery via device implantation is a rapidly evolving discipline that has already become the standard of care in treating medically refractory Parkinson's disease and essential tremor. A wider variety of deep brain stimulation targets will treat additional neuropsychiatric diseases. 9, stereotactic radiosurgery is a powerful treatment option for intracranial disease, whether it is primary or adjunct. Gamma knife surgery can be used to treat tumors, vascular malformations, and cranial neuralgias. The subarachnoid space outside the left medial surfaces of the occipital lobes. The left occipital lobe receives and integrates data from the left half of each retina. A left occipital lesion would therefore result in an inability to see objects right of center. The temporal lobes lie below the sylvian fissures. The hippocampus, amygdala, and lower optic radiations are important components of the temporal lobe and are involved in memory, emotion, and vision, respectively. The receptive speech area typically is found in the area of the left posterior superior temporal lobe and inferior parietal lobe. The basal ganglia include the caudate, putamen, globus pallidus, subthalamic nucleus, substantia nigra, and nucleus accumbens. These structures are involved in the selection, activation, and termination of movement and facilitate learning of appropriate context-dependent motor behaviors. Lying deep to the cerebral hemispheres is the diencephalon, which includes the thalamus and hypothalamus. The thalamus is a key processor and relay circuit for most motor and sensory information, traveling to or from cortex. The hypothalamus regulates homeostasis via the autonomic and neuroendocrine systems. The brainstem consists of the midbrain, pons, and medulla. Longitudinal fibers run through the brainstem, carrying motor and sensory information between the cerebral hemispheres and spinal cord. The corticospinal tract is the major motor tract, while the medial lemniscus and spinothalamic tracts are the major sensory tracts. The nuclei of cranial nerves 2 through 12 are also located within the brainstem. These nerves relay the motor, sensory, and special sense functions of the eye, face, mouth, and throat. The cerebellum arises from the dorsal aspect of the brain stem. It integrates somatosensory, vestibular, and motor information for coordination and timing of movement. Midline or vermian lesions lead to truncal ataxia. Lateral or hemispheric lesions lead to tremor and discoordination in the extremities. The ventricular system is the cerebrospinal fluid, 1,828 containing contiguous space inside the brain, continuous with 6 spinal instrumentation is used for surgical. The subarachnoid space outside the brain. The paired lateral ventricles consist of temporal, occipital, and frontal horns, as well as the main body. CSF travels from each lateral ventricle through the foramina of Monro to the third ventricle, located between the left and right thalami. CSF then drains through the cerebral aqueduct to the fourth ventricle within the brainstem. The foramen of Magendie and paired foramen of Luschka drain to the subarachnoid space. The approximate CSF volume in an average adult is 150 ml, and the choroid plexus produces approximately 500 ml of CSF per day. The spinal cord starts at the bottom of the medulla and extends caudally through the spinal canal to the first lumbar vertebra, approximately. Motor tracts continue from the brain stem down via the lateral and anterior corticospinal tracts to anterior horn cells, and then exit via ventral nerve roots. Sensory information enters via dorsal nerve roots, travels cranially via the dorsal columns or spinothalamic tract, and into the brain stem. Paired nerves exit the spinal cord at each level. There are 31 pairs, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. The dorsal and ventral nerve roots at each level fuse to form mixed motor sensory spinal nerves and spread through the body to provide innervation to muscles and sensory organs. The C5-1 spinal nerves intersect in the brachial plexus and divide to form the main nerve branches to the arm, including the median, ulnar, and radial nerves. The L2's 4 spinal nerves intersect in the lumbosacral plexus and divide to form the main nerve branches to the leg, including the femoral and sciatic nerves. The principal motor tract of the spinal cord is the corticospinal tract. It is a 2-neuron path, including an upper motor neuron and a lower motor neuron. The upper motor neuron cell body is located within the motor strip of the cerebral cortex. The axon travels through the internal capsule to the brainstem, decussates at the brainstem, spinal cord junction, and travels down the contralateral corticospinal tract to the lower motor neuron in the anterior horn at the appropriate level. The lower motor neuron axon then travels via peripheral nerves to its target muscle. Damage to upper motor neurons typically results in hyperreflexia and mild atrophy. Damage to lower motor neurons results in flaccidity and significant atrophy. The 2 major sensory tracts are 3 neuron pathways. Fine touch and proprioceptive signals enter the spinal cord via the dorsal root ganglia and then ascend ipsilaterally via the dorsal columns. Then they synapse and decussate in the lower medulla, travel up the contralateral medial lemniscus to make a second synapse in the thalamus, and then finally ascend to the sensory cortex. Pain and temperature fibers first synapse in the dorsal horn of the spinal cord at their entry level, decussate, and then travel up the contralateral spinothalamic tracts to the thalamus. The second synapse occurs in the thalamus, and the output axons ascend to the sensory cortex. The aforementioned motor and sensory tracts together constitute the somatic nervous system. In addition to this system, the ANS is the other constituent of the nervous system. The ANS carries messages for homeostasis and visceral regulation from the central nervous system to target structures such as arteries, veins, the heart, sweat glands, and the digestive tract. CNS control of the ANS arises particularly from the hypothalamus and the nucleus of the tractus solitarius. The ANS is divided into the sympathetic, parasympathetic, and enteric systems. The sympathetic system drives the fight-or-flight response, using epinephrine to increase heart rate, blood pressure, blood glucose, and temperature, as well as to dilate the pupils. It arises from the thoracolumbar spinal segments. The parasympathetic system promotes the rest and digest state and uses acetylcholine to maintain basal metabolic function under non-stressful conditions. Parasympathetic fibers arise from cranial nerves 2, 7, IX, and X, and from the 2nd to 4th sacral segments. The enteric nervous system controls the complex synchronization of the digestive tract, especially the pancreas, gallbladder, and small and large bowels. It can run autonomously, but is regulated by the sympathetic and parasympathetic systems. Neurologic examination. The neurologic examination is divided into several components and generally is done from head to toe. First, one must assess mental status. A patient may be awake, lethargic, stuporous, or comatose. Cranial nerves may be thoroughly tested in the awake patient, but pupil reactivity, eye movement, facial symmetry, and gag are the most relevant measures when mental status is impaired. Motor testing is based on maximal effort of major muscle groups in those able to follow commands, while assessing for amplitude and symmetry of movement to deep central pain may be all that is possible for stuporous patients. Table 42-1, detailed scoring for motor assessment tests. Characteristic motor reactions to pain in patients with depressed mental status include withdrawal from stimulus, localization to stimulus, flexor posturing, extensor posturing, or no reaction. Figure 42-1 diagrams the clinical patterns of posturing. This forms the basis of determining the Glasgow Coma Scale motor score, as detailed in Table 42-2. Light touch, proprioception, temperature, and pain testing may be useful in awake patients, but is often impossible without good cooperation. Table 42-1. Motor scoring system. It is critical to document sensory patterns in spinal cord injury patients. Muscle stretch reflexes should be examined, often comparing left to right or upper extremity to lower extremity reflexes for symmetry is the most useful for localizing a lesion. Check for ankle jerk clonus or upgoing toes. Presence of either is pathologic and signifies upper motor neuron disease. Diagnostic studies. Plain films. Plain x-rays of the skull may demonstrate fractures, osteolytic or osteoblastic lesions, radiolucent foreign bodies, or pneumocephaly. Plain films of the cervical,